Hello everyone. My name is Mohammad Al-Karagholi, and I am a medical doctor here at the Danish Headache Center. I also did my PhD here. It's actually an honor for me to be here with you. I wish I could be among you. However, the circumstances is not that good at this time as you imagine. We are Dr. Hafiz Amin, and I going to speak about 6 headache cases. I'm going to take 2 of them, and Dr. Amin is going to speak about 4 of them. Actually, we planned it like this, that Dr. Amin could start with his 4 cases, and I will end up with my 2 cases. However, I have to work right now, so I don't have that much time. That's why I will try to start, and after that, Dr. Amin will finish up with his 4 cases. I'm originally from Iraq, and I have been in Denmark here for 15 years old. So I wish I could also speak Arabic in these cases. I will try to do it so. However, I cannot promise that. Let's hop directly to my cases. So I will start with case number 5. Here we have a 52 years old woman came to the hospital at 25 of January 2014. She had a mild headache, and she had actually the following days had several attacks, if very severe headache, and every attacks actually lasted for 15 to 13 minutes. The very nice information we have here from this woman is that the attacks are provoked by coughing and defecation. So we need some pressure to provoke these attacks. We are speaking about 3-4 attacks per day, and they are very severe. And also we are speaking about some neurological findings. We find that we have paralysis of her right leg. We have also migraine history, and it's very interesting because wine, we can maybe think it could be migraine attack. However, migraine attacks cannot come several times during one day. We have ataxia in the arm and the leg. So we have a type of headache here. What kind of diagnosis we have? We move forward. The question is that the headache we are speaking about is sudden headache and severe headache at the same time. And this is the one headache we have here without any premonitory symptoms, without any warning signals. And that's why we have not to think, okay, it's not migraine, it's something different. Could it be SAO? Yes. Could it be some caudal artery dissection? Yes. Could it be migraine because she has migraine history, but she doesn't fulfill the migraine criteria? Because according to the criteria, we need at least 5 attacks of migraine before we can give them the diagnosed migraine attack. Could it be other type of diagnosis? Yes, it can. What should we do here? We can take MR, we can take CT scan with artery sequences. Why with artery sequences? Because the headache was induced by coughing and defecation. So we take also lumbar puncture, and we find that it's yellow water we have from there as indication that we have some old blood in the CSF. We can also call the MR department about the diameter of arteries, and we found that we are speaking about irregularities of arteries. So now we have actually MR scan that confirm we have diffuse vasospasm and also small bleeding. So here, this case, we are speaking about RCVS, and we maybe knew that from the beginning because of three elements here. One, we have sudden attacks, which only last for 3, 4, 5 minutes. We are speaking about that attacks provoked by pressure, and we are speaking about attacks that are not preceded by promontory symptoms. We can use nimodipine of 60 milligram 6 times a day for 3 weeks. And actually, 5 days later, the woman had less headache, and the MR scan 1 month later almost normal. Then actually several months later, she has no headache at all. Now, if you can see, we have this syndrome here. How can we manage this? It's something very interesting here, and I have already mentioned these points here. When are we going to suspect that we have RCVS? This when we have attacks, many of them in one day, and they are provoked by pressure. Maybe also if we have some people using vasoactive drugs as cocaine or something like that, they can also have this type of headache. Imaging diagnosis is very important, and we also have to do the imaging investigations 3 months later, just to fulfill the patients and also to follow the patient's development. Yes, we can find that different construction in different regions of the cerebral arteries, and it's totally normal and totally spontaneous and reversible. And management is to avoid the triggers, is to treat the hypertension, and also to use nimodipine. And the prognosis usually quite good. We need to look at the criteria now as the International Classification of Headache published in Cephalalgia. We can find the criteria here. One of the criteria is a headache with or without focal deficit. In our case, we had focal deficit with the right leg, with the right hand, as you remember, and the headache has one or more of the following characteristic, and this one have we here is acute sudden attack triggered by pressure, triggered by sexual activity, triggered by Valsalva, triggered by something who elevate the pressure, and present or recurring during 1 month or less. If we have this, and we also have the headache resolved within 3 months, because if we are speaking about migraine, it will not be the case here, and we cannot find another better diagnosis for this, then we are speaking about RCVS. Here, more information we have. We already been about this, and we have also our second case. Our second case here. It's my last case, and after that, we will go directly to Dr. Amin. I'm hoping that tomorrow I will be live with you. If you have any question, I will be at your service. We have 17-year-old girl with episodic post-traumatic headache for 6 months. And she came to her medical doctor with subacute severe holocranial headache for 2 days. So we have an PTO, post-traumatic headache for 6 months, but now we have severe headache that the patient cannot recall, and the patient doesn't think that this headache mimic the usual headache after the post-traumatic headache. So what is the differential diagnosis here? We have severe holocranial headache for 2 days, and it's not mimicking the post-traumatic headache that the patient is familiar with. It may be could PTO that is suddenly changing its characteristics. Maybe it can also be medication overuse headache, sinus thrombosis. It can be a lot of differential diagnosis. We need more information here. We go to more information to find more information. We find that the patient has double vision, no other symptoms, no family history of headaches, and no exposition to hormonal therapy, nor medication, no endocrine diseases. So the diagnosis and what to do. We did neurological examination for the patient, and it's actually normal beside the visual disturbances. The patient is, as you can see here, overweighted, and if we do ophthalmoscopy, we find that the pupil is very wide and we have pupil edema. This case actually pointing at some direction, because our neuropathic examination, as I told you, we have this pupil edema and decreased vision. And imaging, we did imaging here, and what should we exclude by doing imaging? We have one important diagnosis, and it is sinus thrombosis, venous vein thrombosis. It's very important to do the imaging to exclude this diagnosis. We did lumbar puncture that it's almost normal. Maybe the pressure of the CSF is higher than normal, but not that much. Blood test was also normal. And here we are speaking about idiopathic intracranial hypertension. And it's very important case. In Denmark here, we have approximately 50,000 of patients with idiopathic intracranial hypertension, and the majority of them are women overweighted. And how to treat the patient with idiopathic intracranial hypertension, I will leave that to Dr. Amin, because he is going to speak about that. I'm going to work. I have a night shift now. I wish you all a very nice conference, and I wish I can be with you to answer the question if you have so. Thank you so much, and I will leave the word for Dr. Amin.
Hello, my name is Hafed Saidane from Rigshospitalet, Denmark. It is an honor to be here, at least online, presenting these cases. I have a couple of cases for you regarding headaches and migraines, just like my colleague Mohammad had. Okay, so we'll just go right ahead. The first case is a case I call a stroke of luck. It's about a 34-year-old mailman with a history of anxiety and prior benzodiazepine abuse, who is brought to the ER by ambulance complaining about inability to see what's happening in the left side of his field of vision for the past 30 minutes. After noting that the patient has a family history of hypercholesterolemia, sorry for that, you're unable to continue history taking due to the patient losing his ability to speak. The patient is visibly afraid. Okay, so we have a visibly afraid patient complaining about visual disturbances who suddenly loses his ability to speak. You do a clinical urgent examination that shows that the patient has a NIHSS, National Institute of Health Stroke Scale, score of 5. He's unable to answer any questions about where he is or what month it is. He's aphasic, and he has mild dysarthria. Okay, so that's 5 points. The main differentials to consider in this case should be possible stroke, possible migraine with aura, and a possible non-organic symptom or a panic attack. Okay, so you do your urgent investigations. The MRI and stroke protocol shows no signs of previous infarctions or acute ischemia. The EKG is normal, the blood panel is normal. The patient is followed up within 90 minutes after admittance to the hospital, and he's now able to speak within 1 hour from the first examination. The patient is still very afraid. He's even vomiting due to anxiety. He refuses to have a headache. And when you examine him and ask him further questions, the patient reveals that he had a shimmering and opaque shape develop in the left side of his vision field, followed by a grayish and opaque shape before finally shrinking into nothing. The patient then lost his ability to put his thoughts into words, but was able to understand. And he also notes that he sometimes experiences pulsating unilateral headaches with exercise intolerance, but he claims that this does not feel like his migraine. So he's very sure that he doesn't have his usual migraine. Okay, but obviously there is something going on here. So how do we get closer to that? Well, his clinical examination, when he returns within those 90 minutes, shows nothing abnormal. And so we still have to consider, is this possibly non-organic? Is it possibly migraine? Based on the presentation of a march of symptoms starting from the visual cortex moving forward without any headache, we have to consider that what he's experiencing right now is a acephalic migraine, or also known as a migraine aura without headache. This needs to be considered when you have young patients with presenting with symptoms that may appear like TIAs. And he may also have migraine without aura due to the history of pulsating unilateral headaches with exercise intolerance. How do we delve into this and clear up what's what? Well, we do need a headache diary first, and we also need to see the patient within a follow-up period, and we can do that within a month. We need about a month's worth of follow-up regarding the headache. And then we have to adjust the treatment based on the headache diary. Does the patient have sufficient attacks to warrant medication and possibly even preventive medication as well? Okay, so that's the first case, a stroke of luck. So this patient didn't have a stroke, didn't have a TA, but had an acephalic migraine and possibly a migraine without aura. Our next case is called Not a Hangover. It's about a 39-year-old male chef presenting in the ER with persisting occipital headache of sudden onset. There's a varying intensity between NRS 7 to 10. It started 24 hours prior when the patient was putting his 8-year-old child to bed. The patient feels unable to stand due to positional worsening of the headache up until 10. He has accompanying nausea and vomitus. He sees shimmering spots in the entire field of vision, and there's a severe light sensitivity. He's otherwise asymptomatic. He has a history of hypertension. He uses amlodipine 5 milligrams per day, and he also has recreational cocaine and cannabis. The examination reveals an elevated blood pressure, and the patient refuses to sit or stand up. And when you do a bedside neurological examination, it reveals a double vision when the patient looks to the left, but otherwise normal, as far as you can get when the patient refuses to stand. We do need to consider some urgent neurological problems here. The patient may have a subarachnoid hemorrhage. The patient may have a venous sinus thrombosis. And the patient may also present with drug-induced RCVS. That's the most urgent problems right now. He may also have migraine with visual aura or possibly an orthostatic headache. How do we delve into this further? We need some investigations here. Our investigations usually include blood panels. They didn't show up with anything. A CT scan was normal. A lumbar puncture, which is a good way to go, was with the dry tap at first attempt, and on second attempt, the opening pressure was not measured, but the CSF turned out to be normal. So no signs of xanthochromia, no signs of neuroinfection. A CT angiogram showed no signs of subarachnoid hemorrhage and no signs of aneurysms or dissections. A venogram was normal. So how do we further diagnose this patient, a suggestion might be to do an MRI. And doing that, what we found was dural thickening and some sagging of the posterior fossa contents. Okay, so what do these findings indicate all in all? It's highly likely that the patient is presenting with spontaneous intracranial hypotension, and it may be due to a dural tear, which you can treat blindly by doing a blood patch. If that doesn't work, sometimes you have to progress and do an MRI with STIR sequences as well to further localize the leak and treat it from there on. But that is highly specialized. Okay, so this is the case called not a hangover, and we'll move on to the next case. Now we have, and we call it still hurts. I like giving my cases names. This case is about a 55-year-old female who works as a nursing assistant, and she's been referred by a GP due to a progressive holocranial headache. It's both pulsating, it's tense, it does have neck soreness, and it's been progressing in pain intensity over the past 4 months. And it's sometimes located unilaterally, but also with shifting location. Her headaches are periodically accompanied by nausea, photophobia, and exercise intolerance. She's also tried taking over-the-counter painkillers daily for 3 weeks without any lasting effect. Now, this woman usually goes to a hammam, but it's been closed due to COVID-19 regulations, so she's unable to get her regular massage, and she hasn't been able to get them for the past 2 to 3 months. And she's also involved in the planning of her daughter's wedding, which is in 3 months from now. And the headaches prevent this patient from participating in the preparation. The headaches have caused several sick days at her job, and she's very stressed about both these things as well. The patient has a history of hypertension and depression, and she's getting, and her medication includes losartan for the blood pressure, 50 milligrams a day, citalopram for the depression, 20 milligrams a day, and when needed, which has been daily for the past 3 weeks, she's been on paracetamol 4 times daily and ibuprofen 3 times daily. Now, you do a clinical examination that reveals that she is overweight. She has an okay blood pressure and diffuse muscle tenderness upon palpation over the scalp and paravertebral muscles from the upper neck area down to about TH4. So it's basically from the top of the head down to between the shoulders. The neurological examination is otherwise normal. And so we have a slightly overweight woman, 55 years of age. She's involved in a physically requiring job, and she's been having progressive headache for the past 4 months. She takes a lot of medication, and she is stressed about things going on in her family, and she has comorbid depression and hypertension. How do we handle this patient? Well, we need to consider, is she having tension type headache? Does she have medication overuse headache? Does she have possible migraine without aura? Does she have side effects to her antidepressant? Or is there underlying space-occupying lesion possibly? Now, we do our investigations, which include blood panels, EKG and MRI, which all come out normal. Okay, so if there's no space-occupying lesion on the MRI and no signs of intracranial hyper or hypotension, the history should be suspicious for medication overuse headache, migraine without aura, and tension type headache. Now, this is a patient with competing headaches, which complicates how we should handle this patient. A thing to consider is that this patient will likely benefit from a stepwise management. first of all, we do need a headache diary. This is first. We need to start treating the medication overuse headache first. Now, there's a very interesting study published in JAMA from our colleagues Louise Carlsen et al. That has showed, it's an RCT, which showed that withdrawal therapy combined with preventive medication from day one, it's the best strategy for medication overuse headache in patients with migraine. And if we have to treat the medication overuse headache, we need to remove her daily use of, we need to eliminate her daily use of painkillers. We need to provide her with escape medication for the first 3 weeks. And if this patient does not use opioids, but if she does, she might be admitted for in-hospital treatment. But usually the medication overuse headache is handled as outpatient in an outpatient setting. Now, when we have taken care of her medication overuse, we may look at the tension type headache. There's some non-pharmacological interventions that we may do. We may start to identify and try to eliminate her comorbid stress. We may evaluate her with a physiotherapist and give her home exercises to do. These steps may already be activated during the treatment of a medication overuse headache, but we cannot start adding any pharmacological treatment for her tension type headache at the same time. We need as far as we can, we need to do it stepwise. Otherwise, we will be unsure how our treatment works with this patient. An interesting thing to consider regarding this patient is that if it turns out via her headache diary that she actually has a chronic form of tension type headache, we may consider giving her preventive antidepressants, and that may be amitriptyline, mirtazapine, or venlafaxine. This might also help her with her underlying depression. Now, if it turns out that there's also a component of migraine in this history, and we base this off her headache diary, we may consider changing her antihypertensive medication for candesartan, which has shown an effect in migraine patients. We may, and as described earlier, we may add amitriptyline if there is this comorbid tension type headache as well. Okay, so a lot of info in this slide, but this patient, I find this case very interesting due to the complexity of it. Okay, now we'll move on to the next case. This is called Blurry, and it's about a 28-year-old female store clerk who has been referred by her GP due to 2 weeks of worsening pulsating holocranial headache. She complains of intermittent nausea and increasingly blurry vision through the past weeks. For the past week, she has tried over-the-counter pain medications. She's been trying smoking cannabis on her shisha she has at home. And she's been trying to resting her head elevated in the bed because lying flat worsens the headache a bit. The patient also prefers using the elevator since walking upstairs worsens her headache. She has problems enjoying music on her headphones due to hearing her own pulse too loudly. So this patient has several complaints, mainly regarding increasingly blurry vision, progressing headache that worsens when she's lying down, and feeling able to hear her own pulse. Now, this patient has a history of 2 normal pregnancies besides hypertension and diabetes during her pregnancies, but not after. She's taking a 2nd-generation P pill, and she also smokes. This woman is overweight. She has And on clinical examination, she has reduced ability to read letters at a meter's distance. She has mild papilledema on ophthalmoscopy, and her neurological examination is otherwise normal. We need to rule out venous sinus thrombosis, and that is the most, that is a urgently treatable disease that needs to be ruled out. When that is ruled out, we can possibly consider that the patient has idiopathic intracranial hypertension, which she is showing signs of. We do standard blood panels that show nothing besides slight hypercholesterolemia. A venogram shows no signs of sinus venous thrombosis. We do a lumbar puncture, which shows an elevated CSF pressure. And voila, we do an MRI, which reveals a partial empty-cella dilated optic nerve sheets. Okay, so partial empty-cella and dilated optic nerve sheets, which are signs of intracranial hypertension. Also, you may see a slight bulging of the optic disc here as well. There is, based on these findings, the diagnosis has to be idiopathic intracranial hypertension, and the way to treat this, going back to, and this is a follow-up on Mohammed's case as well, the way to treat idiopathic intracranial hypertension is pharmacologically with acetazolamide, 1,000 to 4,000 milligrams per day, combined with potassium chloride for the possible side effect of paresthesias. And you can give 750 milligrams per day, 1 to 3 times per day, actually. The recommended starting doses for acetazolamide is 500 milligrams per day, 3 times daily. You may add on topiramate or treat her with topiramate as monotherapy, but you have to titrate slowly over several weeks. This patient also needs an acute or subacute ophthalmology referral for evaluation of if she's a candidate for possible optic nerve fenestration or even a ventriculoperitoneal shunt. Besides the pharmacological and surgical options, the patient also needs to have a weight loss, which may be planned out with a dietitian. With a new diet. So yeah, this concludes my cases, and it's been an honor to present these cases for you. I hope that the cases may spark a conversation about these different headache types and migraine. And I've tried to add as many caveats and interesting facets as possible. So I do hope that you find this enjoyable. All right. Thank you very much.